Pediatric hydrocephalus. Let's understand the terminologies that are there. Communicating hydrocephalus means an extraventricular obstructive hydrocephalus. Non-communicating hydrocephalus means intraventricular obstructive hydrocephalus. The pathophysiology. Hydrocephalus occurs because of an imbalance between production and absorption. It is produced by the choroid plexus, absorbed predominantly by the brain and spinal cord, to a lesser extent by arachnoid granulations. The net CSF flow occurs from the lateral to the third to the fourth ventricle. This is due to the cerebrovascular pulsations. Etiology in children can be divided into two: neonates and infants, usually post-hemorrhage, post-infection, Chiari-2 malformation, Dandy-Walker malformations, vein of Gallen malformation. In older children, aqueduct stenosis, posterior fossa midline tumors, raised intracranial venous pressure, or certain conditions like craniosynostosis. What is the clinical presentation? It can be divided into two: before fontanel closure, those that are less than 2 years of age, and more than 2 years of age. Less than 2 years of age, they usually present with progressive macrocephaly, frontal bossing, calvarial thinning, tense bulging anterior fontanelle, sutural diastasis, enlarged scalp veins, sunsetting eyes, lateral rectus palsy, leg spasticity. More than 2 years, they usually present with early morning headache, nausea, vomiting, papilledema, altered consciousness. It is important to understand what are the sites of narrowing in the ventricular system. The common sites are the foramen of Monro, aqueduct, and the fourth ventricle outlet. Causes of foramen of Monro narrowing includes superior extension of suprasellar tumors, arachnoid cyst, colloid cyst, giant cell astrocytoma. Aqueduct narrowing occurs in textile plate gliomas, superior extension of midline posterior fossa mass lesions like brainstem diffuse astrocytoma, or inferior extension of pineal region tumors. Fourth ventricle outlet obstruction usually occurs due to displacement in Chiari-2 malformation. Communicating hydrocephalus is usually associated with hemorrhage or exudates that fall further down into the spinal canal, or due to pial dissemination of tumors. Another common cause is spinal cord tumors. So one of the primary purpose of treating a hydrocephalus is using techniques like CSF diversion. It can be temporary or permanent. Temporary tends to be usually external drainages. Permanent are ventriculoperitoneal, ventriculoatrial, or third ventriculostomy. In third ventriculostomy, we puncture the floor of the third ventricle and the CSF flows directly into the suprasellar cistern. So what are the imaging findings? In non-communicating hydrocephalus, we usually see plenty of imaging findings. Communicating hydrocephalus can vary from having some ventriculomegaly to being absolutely normal. So let's look at the findings of non-communicating hydrocephalus. The temporal horns are disproportionately dilated to the lateral ventricle body. The anterior and posterior recesses of the third ventricle appear dilated. There will be an inferior bowing of the floor of the third ventricle. Transependymal edema is seen along the margins of the lateral ventricle. Bulging fontanelles. Sulci and cisterns may appear small or obliterated. Some less commonly identified findings are widening of the radius of the frontal horn, a dorsum cellular erosion, or a copper-beaten skull appearance. We need to remember, when we are looking at sulcal spaces in children, we need to know what are the variations that are seen based on age. So if the baby is less than, or the child is less than 2 years of age, a benign enlargement of subarachnoid spaces is a normal condition. Children can have prominent sulci without any underlying hydrocephalus. So the way to distinguish benign enlargement of subarachnoid spaces versus a hydrocephalus is usually with serial imaging to see if there is progressive increase in the size of the sulci. So beyond 10 years, you should remember, into the second decade of life of children, the sulci tends to be less conspicuous. The ventricles tend to be less prominent, and this is normal. So the ventricles can appear slit-like, but the sulcal spaces might not be evident at all. But the basal cisterns will be normal. So that is important. So if the basal cisterns are obliterated, then you can definitely consider a case for ventricular obstruction. So always remember, less than 2 years of age, this benign enlargement of subarachnoid spaces, it occurs due to a disproportion between the rate of growth of the brain and the rate of growth of the skull. So the skull tends to be growing at the 95th centile, while the brain is also growing normally, but not as fast as the growing skull. As a result, this tends to catch up by the age of 2 years, and they tend to normalize beyond 2 years. So this is less than 2 years. You need to be a bit more wary about the sulci and the subarachnoid spaces. So one of the problems in imaging that you would commonly encounter is shunt dysfunction. So if a shunt is in place, and what are the imaging findings that could suggest that there is a shunt dysfunction? One, obviously, is the recurrence of a hydrocephalus in a shunted patient. Second, fluid tracking along the shunt tubing. Any inflammation or fibrosis at the ends of the tubing can result in calcification. Normally, the signal across a shunt, for example, in a third ventriculostomy, from third ventricle towards the suprasellar cistern, you should be able to demonstrate a T2 flow void. In the absence of a T2 flow void, it would suggest that there is a shunt failure. Of course, always there is the possibility of shunt infection, which can begin with ventriculitis, can lead on to cerebritis and fatal brain injury.